Right. So, like, basically, thought I'll go through a small presentation on this unoperated tetralogy of fallow in adult patients. Basically, case scenario, I'll come to that. Just go through a quick agenda on which what you will talk. Because I thought we'll just go through a basic thing and then we'll discuss once the surgeon also get involved. Through the introduction, natural history, clinical presentation, whether to operate or not, and medical management. These are the two main issues coming in. I think we know that most cases are tetralogy are operated by 6 months of age in most good centers. Majority get operated even in other centers by 1 year of age. Only a few percentage tend to survive till the adult life, mostly in this part of the world or the developing world. And obviously, there is no data on unoperated tetralogies coming from the Western world. We don't expect that. And there are not much data at all from this part of the world also to say how and when, or till what age we can need to operate on them. That's a major question. So as we all know, almost only 30% tend to survive beyond 10 years, and only 5% of these tetralogies tend to survive beyond 40 years. Obviously, the scenario is worse in the pulmonary atresia subset. Only half of them survives beyond 1 year, and only a small percentage, 8%, survives beyond 10 years. So what we see in the adult is not many more, or 70%, 80% would have died for one patient we would have seen in adult life. Presentation are mostly by a worsening cyanosis or exertional symptoms, or they may present with heart failure or first time as an infective endocarditis. Few may present with ventricular dysfunction or an arrhythmias. The routine evaluation is fine. You all do the ECG, X-ray, echo for everyone. And then the imaging, ideally, almost all of these adult tetralogies require additional imaging. What is recommended from the West is MRI. But I think in our scenario, due to multiple reasons, we tend to do a cardiac CT or a cardiac catheterization. So it's a case in which recently, 2 weeks ago, a patient came to my OPD as a 54-year-old adult. Is reasonably asymptomatic, we say class 2 symptoms, obviously. Is diagnosed to have a tetralogy 10 years, 15 years ago. Advised surgery, but was not done due to multiple reasons. He was scared. He was financially okay to get operated. On evaluation, he has a loud systolic murmur and a saturation of 86%. An echo shows a large VSD and a pulmonary stenosis, a transthoracic echo. So, a 54-year-old class 2, 86% saturation. The question is, may not done further evaluation for the imaging for the pulmonary artery anatomy, but looks reasonable from the basic transthoracic echo. The question is whether to operate or not to operate. So we'll try to read about this adult tetralogies who are unoperated. Obviously, there are hardly any data except that one article came from Dr. Sachin from Old Institute. So if you're less than 40-year-old, is symptomatic and a reasonable good P anatomy, I think almost all of us agree upon a complete repair. I think no surgeon is going to stop us, or no cardiologist will definitely refer to a surgical repair. But when it comes to beyond 50 years, I'm going to really think before sending somebody for surgery. Even though the dictum is being to operate any tetralogy at any age, but I usually don't refer them as of now, more than 50 years, reasonably asymptomatic. I retain them in medical follow-up. The question comes in this in between 40 to 50 years of age. So I could get only this article. I was reading through this article, I think published in 2014. In Old Institute, they had probably operated over 11 or 12-year period more than 3,000 patients, of which 41 were more than 30 years of age. They're taken as cutoff as 30 years or above. And between this 4th decade, 30 to 40 years, there were 28 patients, and more than 40 years, there were 13 patients. I don't know whether anybody was above 50 years at all. The functional class of these patients were 27 patients were functional class 2, and 14 patients were in functional class 3, the rest of them. When these were operated, the results was around 3 years, around average follow-up, it was 3 years, which is not too long for somebody who's operated. Was supposed to live at least 5 to 10 year follow-up, the ideal. Obviously, we don't have an ideal data, obviously. There was 2 immediate deaths and 1 late deaths. So already there are more than 6-7% of mortality here. The functional class on follow-up was class 2 in 31 patients and class 3 in 6 patients. So that to start off, it was 27 in class 2 and 14 in class 3, which class 3 patients are reduced, nearly half, more than half, but the class 2 patients have worsened. The authors have concluded that it is quite safe to operate upon adult tetralogy. But with this data, I'm even more skeptical of referring even somebody beyond 40 years for surgery. I definitely would like to have the inputs after this about from the surgical side. And just a few words how you medically manage them, I think, which has already been well dealt by Dr. Krishnamar in the previous session. As general care has to be in a specialized center. At this point, I'll just put a point that as area is important, there are a lot of good patients are likely to come up. But the concern is majority of them are, as Dr. KK correctly pointed out, those patients who are inoperable, poor P anatomy, corrected TJPS, complex 200 conversions, in which majority of them who haven't got operated are those likely to be on a lower socioeconomic group. So obviously they don't have money. None of the private hospitals are likely to develop a major program because that is not financially viable to the specific center. Because you can see one slide in which you need a lot of input from electrophysiologists to the nurses to the psychologists to the gynecologists. So what is the money involved in this is a big question mark. Maybe how much government can spend is also another big question. I think leave it at that, but definitely it needs a highly specialized care. Falls is blood investigation, everybody knows it, that you need get high falls INR values. You have to take a low citrate sampling bottle. Pseudo hypoglycemia sometimes seen. Endocarditis is quite high, so you need to specifically prepare them or prevent infective endocarditis. You need to be mandatory prophylaxis for all cyanotic patients, and they tend to have a higher risk for unoperated CSV. Pregnancy again requires quite preconception counseling and avoid pregnancy. And if they become pregnant, again, requires a high multi-expert team to manage them. But then if the saturations are above 85%, you tend to have a reasonably decent outcome, as Dr. Shine had shown. In relative anemia, this is another thing which is routinely missed in evaluation. Many of the cyanotic, even tetralogies come, their HB is 12, and nobody have bothered to give iron supplementation. Or as again correctly pointed out, that might require, many of them have been undergone inappropriate phlebotomy multiple times, which has further contributed to the anemia. So whenever your MCV value is below 80, or some people say even 82, less than 82, you should give supplemental iron. And then if it's lower than that, quite significantly lower, it is even better if it's symptomatic. If you transfuse them, they will be symptomatically better if you cannot offer a curative therapy. Phlebotomies are only indicated if there is hyperviscosity symptoms with the PCV of more than 65 in the absence of dehydration and iron deficiency. You replace 500 ml of blood with 1 liter of isovolemic fluid or saline. So this finally, as this for unoperated tetralogy, you are not a good candidate for this complete repair. The main thing is risk reduction. This small chart has been copied from the European guideline, in which say the following exposure activities should be avoided: pregnancy, iron deficiency anemia, dehydration, infectious diseases like influenza, and appropriate vaccinations. Avoid smoking and drug abuse. Transvenous leads to be avoided. Strenuous exercise and exposure to heat. And other risk factors include especially careful about air filter in the intravenous line to prevent air embolism, consultation with a good cardiologist and any good team before you're doing any interventional or surgical procedure, prompt therapy of other infections, and contraceptive advice. To conclude, only a small percentage of tetralogists tend to survive to adulthood. To most adult patients, complete correction can be offered with risk increasing appropriate age. Thank you.
Dr. Sunil Kaushal is going to present his surgical aspect. Sunil, you need to unmute yourself.
Respected chairperson, dear colleagues, I'm grateful to the PCSI for providing such an opportunity to me. The tetralogy fellow is the main feature is the underdevelopment of conal septum along with anterosuperior leftward migration, which will lead to malaligned VST and aortic override in fundibular PS and RVH. The Mayo group was the first one to did on pump repair in 1955. This particular specimen is showing all four features of the tetralogy fellow. You can see the migrated conal septum along with infundibular PS, the model-line VST, aortic override in RVH. This particular specimen is showing the from the LV side, aorta is more committed to the RV. As we can see, the larger yellow line and the smaller, the red line, which is on the left ventricle side. This histogram suggesting that 40 to 70% of the patients have aortic override, this degree of aortic override. So all these specimens showing various types of VST in tetralogy fellow, the marline VST doubly committed, and AV canal type inlet type VST. So Dr. Edwin will be telling us more about the clinical features and the diagnostic workup of the adult tetralogy patients. So as most of the patients die before 5 to 7 years of the age, so we should try to catch them young for the better outcome. So infundibulum plays a due role in preserving the RV by its two function, that is a passive role in contraction of distal RV and the peristaltic mode, which is crucial for the delayed opening of the pulmonary valve and the emptying of the RV, of the distal RV. So if we cut more into the infundibulum or go for the longer ventriculotomy, the RV dysfunction will be more. So likewise, the both RV and LV functions are interlinked to each other because of the encircling superficial fibers, which usually happens in even normal individuals. But tetralogy patients, there's a study suggesting that even deeper muscle fibers are also encircling both RV and LV. So if RV dysfunction is more, it will engulf the LV also into itself. So adult TOF is a different disease altogether because of the various types of collaterals, bronchial or MAPCAs, or pre-existing shunts, or because of the severe intense myocardial hypertrophy and myocardial hypoxia. All with these things will lead to biventricular dysfunction, TR and AR. And because of these reasons, there is a poor tolerance of post-op pulmonary regurgitation, or if the regurgitation infection is more because of these non-compliant ventricles. So likewise, polycythemia and coagulopathy also plays a role in bad mortality and morbidity outcome of these patients. These things can be expressed itself by thrombosis, brain abscess, stroke, myocardial fibrosis, multi-organ dysfunction. So because of these issues, preoperative stabilization is must. So coagulopathy and polycythemia can be tackled by hydration therapy, platelet lipid transfusions, medicines like vitamin K and folic acid, vitamin B12, and we don't prefer phlebotomy these days. So arrhythmia needs to be managed, MAPCAR needs to be controlled either in cath lab or in OT before going ahead with the surgery, main surgery, and other organ dysfunction needs to be tackled and clearance to be taken from the specialist. Diagnosis of TOF physiology in adults is itself an indication for surgery representation. So aim of the repair remains the same. The RV hypertension has to be relieved and RV needs to be preserved as much as possible. Infundibulum, RVOTO, infundibulum needs to be dilated, preferably through the trapezoidal inflow approach. And if you are not able to handle it, then trans-MP or the trans-minimal ventriculotomy approach needs to be adopted. And VST needs to be closed by avoiding the conduction bundle. So decision has to be taken by that whether patient needs shunt or one-stage repair on the basis of pre-operative workup and the basis of pre-repair surgical findings like pulmonary artery size and pulmonary annulus size. The surgical approach is preferred, which will lead to good exploratory exposure. No coronary artery is damaged, excessive muscle resection is avoided, and pulmonary annulus or pulmonary valve is preserved. So as much as possible. So transaxial transpulmonary repair is the most preferred one as it fits the bill. Because of these issues which I described earlier, the myocardium, such myocardiums don't tolerate the excessive resistant fraction, that it is PR, severe, acute, severe PR. So it's better to put a monocusp or bicusp valve into the RVOT if there is a longer ventriculotomy for better RV preservation and avoidance of low cardiac output syndrome and other morbidity. The post-op care includes the preservation of RV after the surgery, the taken care of RV dysfunction by anodilators, touch of ADR, high filling pressures, and bleeding needs to be controlled by meticulous chest closure and by multiple transfusions of platelets if needed, fresh blood as well. And arrhythmia and even sinus tachycardia should be avoided. And we should try to maintain the reasonable SVR hematocrit because they are used to it perioperatively since long. If not tackled the way they should be, then the patient might develop low cardiac output syndrome, arrhythmias, severe ventricular dysfunction, ascites, multiple effusions, third space collections. So the residual lesions might worsen the things further. So still these patients can have post-operative issues like root dilatation, worsening residual issues, transit annular patch aneurysms, LPA, which can lead to for re-stenosis of LPA, severe PR, severe TR, arrhythmias, so impaired autonomic or cardiac performance, infective cardiovasculitis, and even sudden cardiac death. So I'm sharing with you three interesting cases of severe TOF physiology patients we operated last fortnight. The first one was 31-year-old nursing staff in medical college. He had tetralogy fellow with severe fundibular valvular TS, and but VST was partially closed by septal leaflet, and VST was AST was also restrictive. Probably that led to severe RV dysfunction and severe TR, and malignant tachyarrhythmias, for which he was admitted repeatedly. You can see the physical anatomy here. The septal margin commissure descended medially, inferiorly, and infundibular os is they are just behind this leaflet, behind this papillary vessel. So this we cannot approach RVOTO because of this fusion of the commissure here and the papillary vessel. So we took off this centroseptal leaflet from the you can see the infundibular os, adequate resection, and accepting RVOT, and VST was closed here. And we put the tricuspid leaflet back to the annulus and repaired the tricuspid wall as needed. And TR came down from severe to mild. So another boy, 17-year-old boy, he had situs inversus dextrocardia, DORV, restrictive VST, and severe PS. So we also came with the same symptoms, severe hypercyanosis. This is pre-repair morphology. You can see the dextrocardia, situs inversus. So I come down to other side to take care of the VST. The VST was enlarged, you can see here, and the interpreted sutures are being placed through the RA from the right side. So the MP was opened, a trans MP and minimal ventriculotomy, and dedicated section was done, completed. RVUT repair was completed from this side, and patch was put. You can see the sinus rhythm and well-contracting RV. So another nursing boy still studying, a 22-year-old mesocardial DRV Malpus grade versus multiple VST with severe PS. You can see the multiple VST here. On CT, it showed two, three small collaterals which were not recorded because they were tapering out distally, and multiple VST and aortic override. This perioperative pre-repair surgical morphology. You can see the alcove aorta and the small RM. So the VST was too big to root from one side, so we routed it from the two approaches. One transatrial approach, the inlet and the pancreas portion was tackled from this side, and the rest of the portion was tackled from transaortic route. You can see the LV aortic tunnel here. And the RVOTU and MP was tackled from the dextroposed pulmonary artery, which was opened, and wall was tackled here. And a small pericardial patch was put. You can see the distended, it's a well-contracting RV sinus rhythm. It's a well-opened RVOT, LVOT zone, and a small residual VST in the muscular patch. All three came together and all three went home together. 3 musketeers. Thank you very much.